No.
Amazing.
There we go, we're off. So I will start letting people in.
Hi, everyone. We're just going to give everyone like a minute or two to start trickling in, and then we're going to get started. Thanks for coming. Hi, everyone. We're just going to give everyone like one more minute to join, and then I promise we're going to get started. Super excited to have you guys all here today to learn about marine envenomations. All right, so as people start trickling in, we're going to go ahead and get started. So welcome to the University of Miami Wilderness and Emergency Medicine Lecture Series. Super excited to have you guys all here. Before we officially get started, I have one of my new board members, Nikos, is here, and he's going to go over some ground rules. So Nikos, take it away.
Hi there, guys. So yeah, as Shilpi's just mentioned, this lecture series is kind of growing out of what it has already been being based in Miami. We're trying to make an international board of students to kind of represent wilderness medicine. And so this is the transition phase for it now. So in today's talk, just a few ground rules before we start. If I can ask for all of you guys to have your mics off during the talk, but feel free to keep your videos on. Makes it all a little bit more interactive for our speaker, Dr. Barry, and everybody involved. If you have any questions at any point during the talk, please write them in the chat. I'll be here keeping tabs on the chat the whole time. And come the end of the talk, we'll make a point of going through all the questions with Dr. Barry, and any left over, we'll get a written response to at the end.
Yeah, awesome. And yeah, if you have any questions, feel free to send either me, Nikos, or Claire something through the chat, and we will try and help to the best of our abilities. So with that, super excited, as we mentioned, and as Nikos gave a great introduction, my little project here at UM is going international, and I now have an awesome group of students from all over the world that is helping me take this project to the next level. The next two slides basically has pictures of these wonderful human beings who you will be seeing more of, and you will be seeing less of me as they slowly start to take this over and we do transition this. But that being said, with this new group, we're hoping to have new programming, new opportunities, and a whole bunch of new wilderness programming. So don't go anywhere, stay tuned. We have a lot in store for you guys, and I'm super excited to be working with this awesome group of people.
Okay, hello everyone. My name's Claire. I'm an MS1 at University of Miami Miller School of Medicine, and I'm so happy to be working with you guys and getting involved with this project. So I'm going to be taking over Shilpi's role today and talking a little bit about our mission and introducing our speaker. Overall, our mission is to expose interested students and healthcare professionals to the breadth of wilderness medicine and emergency medicine. And it's an opportunity where students can learn and engage in wilderness medicine beyond our current constraints of being stuck behind a screen. With this lecture series, we aim to showcase the diverse spheres in which healthcare professionals can make an impact and inspire everyone to hopefully start thinking abstractly about the way we can utilize our careers in healthcare and medicine. And finally, we want to create an international community of wilderness medicine enthusiasts and experts committed to promoting a diverse and culturally competent environment. Here's a quick summary of what lectures you can look forward to in the future. We have weekly talks on different subspecialties once a week, featuring different physicians and specialists at the top of their fields. I hope you guys are as excited for these speakers as I am. And I want to give a special shout out to our amazing speaker next week, Dr. Christopher Van Tilburg, who's going to be talking about rescue medicine. So I hope I can see all your beautiful faces there next week. Now to introduce our amazing speaker this week, we're so happy to have Dr. Robert Berry here to speak about marine envenomations. Dr. Robert Berry is a PGY2 at the Jackson U Miami Holy Cross Emergency Medicine Residency Program. Prior to this, he completed his medical education at Stony Brook School of Medicine in New York. While growing up, Dr. Berry split his time between Los Angeles and Honolulu, where he enjoyed a variety of ocean-faring activities, including surfing, diving, and fishing. Dr. Berry has had the privilege to explore much of the South Pacific, including Micronesia, French Polynesia, Fiji, Palau, as well as some of South Asia, Central America, and the Caribbean. His passions and interests in dangerous marine animals and marine environments comes from experiencing more of them firsthand than he would have liked. So we're all very lucky to hear him speak today, and I can't wait to hear what he has to say. So if you'd like to take it over, it's all yours.
All right, let me go ahead and share my screen. And then, can you guys see the PowerPoint? It's going okay? Perfect.
Looks good.
All right, welcome everyone. My name is Rob Berry. As they just said, I'm a PGY2 at Jackson/UM/Holy Cross. So I'm talking to you from Miami this evening. Happy to have you guys here and excited to talk about some fish. No disclosures, sadly, for this talk. And I just want to start out with kind of going over what I want to cover. So first and foremost, marine envenomations are relatively rare in the scheme of things. They're not going to be your bread and butter case. You're going to see far more heart failure, kidney disease, other things like that every day in the hospital. And in my experience, especially if you're somebody who likes being in the ocean, you're just as likely to experience one of these patients on scene as opposed to in the hospital. So first, I want to talk about kind of first aid, what to do on scene if you are there when a patient gets stung or bitten. After that, we are going to talk about kind of general concepts of medical care in the hospital setting. Once we do that, I want to go through kind of a list of species and identify the more clinically relevant or interesting ones, though, but it's no means exhaustive. We have a limited time, so I had to make some cuts. And when we do that, I'm going to try to highlight the differences in care. A lot of it is similar between species, but there are some important differences. So I'll try to make a point of those when we get to them. First category I want to talk about is animals that sting. So fish, rays, and jellyfish. General concepts. So first and foremost, and this goes for any kind of field or emergency medicine when you're outside of the hospital, don't put yourself in danger to help your patient. You can't help them if you become incapacitated. So if you're at the beach and your friend starts screaming in the water, don't run out and put your foot in the same hole he just stepped in, because then you're not going to be able to help anybody. Make sure you're safe. Once the scene is safe, the next priority is to try to get the patient away from anything else that can hurt them. Often these stings can be very, very painful. There's a high risk of drowning or injury from some other external stimuli. So try to get them up on the beach, try to get them on a boat, get them somewhere where you can actually take care of them. Anything that stings you with something. And oftentimes this can be left in the patient. So take a look at the wound. If there's a barb or a tentacle still wrapped around him, anything like that, it's a good idea to try to remove it. Sometimes you can actually get further envenomation once it's no longer attached to the animal. So by removing it early, you may actually be preventing a very poisonous load going into the patient. There are some caveats to that. Sometimes like a barb can get impaled somewhere where it's dangerous to remove. This could be the abdomen, the thorax, through a joint, and an eye, in which case you got to use your clinical judgment. If you think you're going to cause more harm than good by taking it out, then by all means leave it in. If you are going to leave it in, it could be a good idea to try to secure it with some kind of bandage or dressing to prevent further lodgement or dislodgement during transit. Kind of in the same vein, some of these things have venom apparatus that can cause significant trauma. You can see things like arterial lacerations or other things that need to be intervened quickly to try to save your patient's life. Do what you can to control bleeding if they are bleeding significantly. Usually pressure is enough, but if there is an arterial laceration or something along those lines, you may need to use a tourniquet or a ligature dressing or whatever you have on hand. That being said, ligature tourniquets and pressure dressings are not generally indicated for fish that sting you, okay? You don't use them to control the spread of venom through the body. As a first-line treatment for fish that sting, hot water is excellent. A lot of the venom is heat labile, and you'll actually start breaking down the venom itself as well as treating the pain. So that's if the one thing you remember is hot water, that's a great thing to take away. Generally, what you want to do is start with about 43 to 45 degree water. As you can see, that should be under the pain threshold right here. And if you can, you want to try to have them put not only the part of their body that got stung, but their whole arm or some unaffected skin in the water. That way the patient can kind of self-triage and make sure it's not too hot, make sure they're not staying in too long, and prevent them from cooking. Speaking of cooking, oftentimes we'll use lidocaine in the emergency department and it works great for pain, but please don't do hot water after you've anesthetized the patient. There are many case reports of people cooking their fingers or other unpleasant stuff. So please do not cook your patient. Once you get them to the hospital, first thing you want to do is control pain. So as I alluded to before, local lidocaine works wonderful. A lot of the pain is concentrated around where the actual sting happened. And if you can kind of numb it, you can help them quite a bit. That being said, sometimes it's not enough. You may need to escalate. Don't be afraid to use parenteral opioids or any other adjunct medicines that you think are required to control your patient's pain. And then you want to take a good look at the wound, all right? These wounds are often dirty. They can have foreign bodies. You need to explore. You need to dig through and make sure there's nothing left in the wound that can hurt the patient. Imaging is a good idea. Usually plain films will pick up most things, but sometimes it's not enough. Sometimes there are small bone shards or other things like that that are better picked up on ultrasound. So use everything you need. And if it is an extensive wound, you might need to get surgery. You might need to bride some dead tissue or something like that. A lot of the wounds can become necrotic. Don't forget life-saving tetanus if they're out of date. We always give it for however much good it does, but I would definitely give it to patients if they're out of date with it. And then you want to consider antibiotics. Most marine stings or wounds I would consider dirty as a general rule. There's some organisms you have to cover that you don't have to think about on land, primarily Vibrio, which can cause a very, very bad progressive cellulitis and myositis. So if you come in and you see a patient's leg looking like this, be worried. You need to get surgery involved and give them aggressive antibiotics. You take it with a grain of salt though. If you have an immunocompetent patient who just has a scrape, you can usually get away with some topical bacitracin and cleaning the wound. But if somebody has a marine wound and it's actually caused by like a stinger, I'm probably going to give them some antibiotics to go home with. Doxy is a good choice to cover the Vibrio, and then you can give them a first generation cephalosporin. If you're going to keep them inpatient, you probably want to use a third generation cephalosporin. Ceftazidime is what I've seen recommended in the literature, just due to resistance to ceftriaxone. And along with that, you probably want to give Doxy or Bactrim with it. Once you've got the patient stabilized, you need to observe them for systemic toxicity. Some of these animals are quite venomous and they can have catastrophic kind of effects on the patient. So deal with whatever's going on, do your ABCs, make sure they're stable, and try to figure out what stung them. Familiarize yourself with the course, and that way you'll get a better idea of what you can expect in the future and if they're safe to dispo or if you need to get them into the hospital. Last but not least, some of these animals do have antivenom available. Usually it's the more dangerous ones. So if it is available, it's kind of worth memorizing or having in the back of your head which animals you can get it for. Depending on where you work, it can take a long time, so don't be afraid to call for it early. And whenever you get antivenom or whenever you administer antivenom, be ready to treat anaphylaxis. All right. First category of species I want to talk about are venomous fish, and we're going to start off with a good one. This guy is the stonefish. So the genus Synacea, and it's found in the Indo-Pacific regions, which are Indian Ocean, tropical, subtropical Pacific. It can be found elsewhere too. It's also in Florida. And this guy gets his name because he does his best impersonation of a stone. He's probably the most venomous fish in the world. And they typically have a darker coloration, a kind of mottled outline. And you'll find them on either the seafloor or in coral or rock, blending in and trying to not be noticed by predators or prey. They're ambush hunters. They are carnivorous. So they kind of sit there and they wait for small fish or whatever to swim by, and they'll lunge out and grab them. And their defense mechanism is primarily not to be noticed. That works really well for sharks and grouper, other things that might eat them, because if they don't see them, they're not going to eat them. But it kind of backfires with humans because we don't realize that they're there, and oftentimes we'll end up stepping on them or putting our hand on them. That's when people tend to get stung. They sting with this row of dorsal spines right here along the back, and they can actually hold them erect when they feel threatened. So typically that's what you'll see. You'll see a stone with a line of spines, and if you see that, you don't want to touch it. If you do end up stepping on it or putting your hand on it, what you're going to see is they have these long kind of barbs. They're actually more like hypodermic needles. There's a central channel and it's covered by the dermis. When you step on it, you're going to press the dermis down, and that's going to compress the venom gland, which causes all the venom to shoot up through like a hypodermic needle. There's some cool videos on YouTube, and I've actually been surprised. They'll have somebody who's like found a stonefish and they'll take a sandal and they'll press down on the spine, and you'll see a huge amount of venom shoot up into the air. So you can get a very large envenomation with just, what appears to be a very relatively minor wound. The predominant symptom, if you are stung, is pain. It often hurts quite a bit. This is a patient where they could step on it and have so much pain they could pass out and be at risk of drowning. Usually the pain will kind of grow and grow and grow over about 10 minutes, then level off and stay very intense until you treat it. The wound is initially ischemic and will typically turn almost like a hemorrhagic blister, and you can have very significant swelling along with it. The pain can then generalize along the limb and even involve the lymph nodes of the nearest lymph nodes of where they were stung. And then systemic symptoms are actually relatively common, as you could expect with the most venomous fish in the world. Things like pulmonary edema, cardiac failure, and even cardiac arrest have even been reported. You also get a variety of other symptoms. People will complain of paralysis, nausea, GI, abdominal pain. But these are the primary ones that I'd be concerned about. Even after, if the patient survives and they do well, the pain and swelling can persist for months. So it's by no means fun to get stung by one of these guys. So what do you do if somebody is stung by them? Well, first and foremost, apart from what we already talked about, is I really want to highlight hot water. There are some case reports from doctors who, I think it was back in the 40s when you were allowed to carry morphine with you in your travel bag, he was on a tropical island and he stepped on one of these fish, made it back to his camp and took morphine, didn't do anything. And then he used hot water and he had almost immediate relief. So really reach for the hot water in this guy. If people still have pain, the lidocaine, and if you need para-enteral opioids like Dilaudid, those are good things to reach for. This is not somebody I'd spare pain medication on. And definitely cover them with antibiotics. These wounds are going to be pretty dirty. Oftentimes you'll have a piece of the spine break off. And like I mentioned, it's hollow. So sometimes it won't be picked up on x-ray. So ultrasound is a good thing to go for. These animals do have antivenom available. So you're going to be doing your ABCs. You're going to be doing symptomatic care, intubate them if they're having respiratory distress, do compressions if they're going to cardiac arrest. But if they're having any systemic symptoms at all, I'd call very early for the stonefish antivenom. This can be life-saving. And if somebody was coding and I knew that they had been stung by one of these fish, I would actually give it intracoat to try to save them. One final note is that the swelling can be very, very extensive, and there have been reports of compartment syndrome associated with it. This can be hard to pick up on because there's so much pain from the sting itself. So just have a high suspicion, and if you feel the compartment's getting tense, evaluate early. Next, we're going to kind of broaden the topic and talk about scorpionfish and lionfish. The stonefish is actually a member of the scorpionfish family. So I want you to think of these fish kind of on a spectrum. These are scorpionfish. They tend to look very similar to the stonefish, and they have similar behaviors. And then there's a subfamily of the Scorpiondae class, which is the pteros or the lionfish. These guys are related, but they have a very different behavior. These guys tend to hang out on the bottom or ambush predators of the dorsal spines as well. These guys are a little more free floating, very easy to recognize, and they rely on predators recognizing them and knowing from their appearance that they're no good to eat, in addition to having these long dorsal and pectoral spines to kind of ward them off. On the scale of things, the venom from a lionfish is probably the least venomous. Scorpionfish is a group or somewhere in the middle, with stonefish being at top. The sting and the symptoms are going to be very similar, with systemic symptoms being less common, particularly with the lionfish. The stings will often have the same kind of progression of swelling, blisters. You can get a generalized rash, and even some tissue necrosis has been reported with these animals. I would treat them the same as a stonefish sting, with the exception of no antivenom for these. So just symptomatic treatment. And if the patient is not having systemic symptoms, often they can be discharged home the same day. A little plug, because I am talking to you from Florida, lionfish are invasive. I don't know exactly how they got here. There's some stories about like a hurricane that broke an aquarium or something like that, I think 15, 20 years ago. But as it is, they're widespread, they're voracious carnivores, and they've been devastating our ecosystem down here. So if you are down here, you can do your part and take part in a lionfish derby where you'll go on a group and spearfish. You do not need to have a license to catch them. Just if you do, make sure you have the adequate equipment. A lionfish caddy, trauma shears work well to take off the spines. You can still get stung even after they're speared, so be careful. And you can eat them. They actually taste pretty good. They're very buttery, taste a little bit like grouper. You can buy them at Whole Foods sometimes. So if you are in Florida, I encourage you to do your part and catch some lionfish. All right. I'm sure you guys have heard of stingrays before. This is a large group of cartilaginous fish, closely related to sharks and skates. They can be found worldwide in tropical and subtropical waters. And there are many different species. A stingray is differentiated from other rays just by the presence of a caudal sting down here. They're typically not aggressive. As you can see, they can sometimes be quite friendly. There are places in the Caribbean where they'll take you and they'll feed them and they'll come up and you can pet them. They're actually very, very soft. So a very cool animal to interact with. And they use their sting for defense. A lot of these animals, what they'll do is they'll bury themselves in the sand, or they'll cruise over the sea bottom looking for mollusks or snails, other things that they like to eat. And somebody will be chomping along and they step on them. Other times people will be chasing them, trying to grab them. And when they feel threatened, they whip their tail around and try to hit whatever's attacking them with this barb and back. You can see it's a pretty nasty implement. And some stingrays actually have multiple of these stings. So they can cause significant trauma. A recommendation that I would make is whenever you're walking on a soft, sandy kind of seafloor, don't lift up your feet and like step, shuffle. That way, if there's a stingray, you're going to nudge them and they'll hopefully swim away instead of stinging you. I had a personal experience where I stepped on one and I can tell you it's no fun. So compared to other venomous fish, these have significant ability to cause trauma. I think the most well-known case is probably Steve Irwin. He was killed by a stingray, unfortunately. And it wasn't the venom, it was because the barb itself actually hit him in the heart. Okay. So where someone gets stung is going to make a big difference to your medical care. This poor gentleman got stung in the crotch, and this would definitely fit into the category of do not remove on the beach. As far as the venom itself, typically, well, in my experience, it feels almost like a boiling knife kind of lancinating into you, and it grows and grows and grows over about an hour or two until you start treating it. I've been told that if you don't treat it after an hour or two, it kind of starts to level off, but it can persist for days after that. Local ischemia and tissue necrosis has been reported and is not uncommon. So if you get hit in the foot or a toe, it's a possibility you might lose it, like this gentleman here. Hot water works very, very well with it. Oh, sorry. And it's what I used when I got stung. I can tell you it helps quite a bit. You can also use lidocaine and everything else we talked about. The one caveat I would say for these guys, apart from the being able to treat the trauma and expecting the more severe trauma, is you often get foreign bodies and the wounds are quite dirty. You can see all these little barbs along the tail, right, or along the sting right here. They can break off. They can be difficult to find. So definitely get imaging, definitely give antibiotics, break out the ultrasound or explore the wound, do what you have to do. Next, we're going to talk about the weaver fish. This is in the family Trichidinae, and it's typically found, it can be found in the South Pacific and warmer waters, but I usually think of it as being in the North Atlantic. I've seen them around Costa Brava in Spain. You can see them off the coast of the UK. There are a lot of stings that come from there. So kind of the Atlantic and the Mediterranean is primarily where you're going to find these guys. They get their name from the Old English word wyver. It got shortened to, or I guess changed to weaver as time went on. That's because when people observed them, they think they had a very snake-like kind of mannerism about them. They're also ambush predators. They tend to bury themselves in the sand and lunge out at whatever's passing by. Compared to the other fish we've been talking about, where they're primarily defensive, these guys have been known to be territorial and relatively aggressive. They sting with these black dorsal spines up top. They also have something called an opercular spine, which is around the gills. So there are a lot of stings where fishermen will hook it and they'll try to go into the gill slit to hold it after, to get it off the hook, and end up stinging themselves on there, on the opercular spine. As far as the wounds, this venom is actually both hemotoxic and neurotoxic. I've heard multiple reports from very, very painful to not that bad. There are a lot of fishermen stories of they get stung by a weaver fish and they end up cutting off their own finger to deal with the pain. I also read a letter from like a UK family physician office where he said that he lets the secretary handle all the weaver fish stings because all you got to do is run it under hot water and it's not a big deal. Systemic symptoms tend to be less common, but they have been reported. You can have some kind of bizarre, strange ones. This is a girl who developed complex regional pain syndrome and couldn't walk on her leg after the sting. But usually you'd expect kind of an ischemic wound that would then blister, turn swollen for a little while, and you can have persistent pain lasting up for months. For treatment, hot water first works very well. Lidocaine, everything else we talked about, antibiotics, parenteral opioids, whatever you need to do. But something I wanted to highlight is because these fish tend to be a little more aggressive, you can sometimes get injuries that aren't on the hands and the feet. They can be elsewhere on the body. This is a lady who got stung in the neck. She also got stung on the arm and the leg, and it caused a arytenoid swelling. To be fair, they also injected lidocaine into this area, so maybe they didn't help the situation. But just treat the patient that's in front of you. A lot of these cases, or a lot of these fish, you don't get a lot of stings every year, so the clinical course is not always well characterized, and people tend to have kind of weird reactions or individual reactions. So if a lady comes in, she got stung in the neck, evaluate her for respiratory distress. Do everything you have to do and make sure you're taking care of your patient. This lady ended up staying in the hospital for about 7 days due to the swelling and other symptoms. And interestingly, I mentioned that the venom is hemotoxic as well. So her hemoglobin dropped from about 13 to 10 and stayed at 10, like kind of the entire stay, and never bumped back up for a while. So I don't know if that's from the venom or something else. But if you are dealing with a weaverfish sting and you're concerned about anemia or having these kind of bleeding diatheses, definitely something to keep in mind. All right, switching gears a little bit, we're going to talk about venomous coelenterates. These are your jellyfish and your anemones, and they're primarily categorized by the presence of the stinging cell, the nematocyst, okay? Think of this as a preloaded stinging gun ready to go. It's a cell that has a tubercle curled up in it, and when it gets triggered, usually they have a touch-sensitive nidocil, but they can also be triggered by changes in salinity or pH. It'll shoot out and has a barb on top. It'll penetrate the dermis, epidermis, go into the skin, and this is what pumps the venom into you. Once these cells are formed, they're fire and forget, so they're not going to reload themselves. But that means that just because it's no longer attached to the animal doesn't mean it can't sting you. So keep that in mind. There are a lot of myths associated with jellyfish and whatnot. I can tell you right now, there's no indication to pee on anybody. But one thing that's different with these animals as opposed to fish that sting is there's a high likelihood that you can actually cause further envenomation if you're removing a tentacle or something wrapped around a person. Oftentimes, not all the nematocysts will trigger when it first hits the patient. So if you're tugging on it or rubbing it off or scrubbing it, you can actually cause further envenomation. So you want to be careful. There are a couple different strategies for this, and we'll go into them species specific. I know vinegar gets bandied around a lot, but you actually have to be careful. Sometimes that'll actually trigger nematocysts and make things worse. And fresh water is always going to trigger them, no matter what species. So a good kind of rule of thumb is if you don't know what stung you and it looks like a jellyfish, use seawater. They live in the ocean. The seawater is not going to trigger the nematocysts. You can use that to kind of irrigate the wound and get it off. The first species I want to talk about is the Portuguese man of war, the Phasalia phasalias. It's a marine hydrozoa, so it's a colonial organism found in the Atlantic, Pacific, Indian Oceans, primarily tropical and subtropical. It's a surface-dwelling animal. It has this float up top, and it trails its long tentacles underneath it. They can get quite long, and it uses them to kind of trawl and catch food. They're wind-driven, and they get their name because I guess somebody saw them early and kind of squinted and thought they looked similar to a Portuguese warship with the same name. So that's how they get the Portuguese man of war. And because they are wind-driven, oftentimes they'll be brought, pushed by the wind into a reef. The tentacles can get shredded up, and you'll have little particulates of it floating around that can sting you. And oftentimes they'll often get pushed up on the beach. Kind of like I mentioned before, just because they're on the beach or it's dead does not mean it cannot still sting you. You can absolutely get stung by a Portuguese man of war on the sand if you touch its tentacle. They do not have any stinging cells in the mantle, so if you wanted to, you could handle that safely. And in this case, you definitely do not want to use vinegar. Vinegar will cause discharge of any unfired nematocysts and make things worse. So seawater is what you want to rinse with here. If you do get stung, I can tell you from personal experience, it starts as a very sharp sensation and then kind of generalizes to an ache. Usually it'll crescendo over a matter of minutes to hours and kind of level off and get okay on its own. And it can kind of encompass the entire limb, spread to joints, lymph nodes, surrounding tissue as well. The typical wound pattern is this kind of pinpoint red lesion that forms a whip-like chain, almost described as a ladder sometimes. It can become extremely pruritic after the fact, and it can be very, very itchy, which is something to keep in mind. Usually patients do okay with this. Hot water works very, very well from personal experience, and I've never needed to go to the hospital for systemic symptoms. I've never known somebody to go to the hospital for systemic symptoms personally, but people who get these very severe envenomations sometimes do report abdominal pain, nausea, vomiting, and deaths actually have been reported. So if you see somebody with a significant wound or a large area of envenomation, definitely be on the alert. As far as pain control after the fact, topical lidocaine, topical steroids, antihistamines usually do a pretty good job. Ulceration and scarring is relatively rare with these animals, luckily, despite how angry these wounds look. And apart from that, yeah, people will usually not need to be admitted for these Portuguese man of war wounds, unless for some reason they're having severe systemic symptoms. The next jellyfish is kind of the polar opposite. This is the Chironex fleckeri. It's the box jellyfish that people mean when they say box jellyfish. Most venomous jellyfish in the world. And to be fair, Cubozoa or box jellyfish is actually a large group of different animals. So not all box jellyfish are the Chironex fleckeri, but this is what people usually mean when they say it. It can be found usually off the north coast of Australia, up through New Guinea and the Philippines and even South Asia. There are multiple species that can act similarly. So the true distribution of animals that sting like this is probably a little bit broader than that. So don't be surprised if you encounter a sting somewhere that's not in this little circle right here. They are relatively medium size, I would say. The bell can grow to be about 30 centimeters, but they're typically relatively small, about the size of your palm. There are no stinging cells in the bell. So this is something, again, that you can handle. But on top, I don't know why you would, but you can safely. All the stinging cells are in the tentacles down here. And this is something that you definitely do want to use vinegar for. So with a Chironex sting, vinegar will actually go ahead and inactivate all the nematocysts that have not been fired. So the recommendation in places that have these is to use it immediately and try to irrigate it with vinegar. Oftentimes you'll find vinegar on the beach in places like Australia or where these animals are endemic. And that's a good indication that you should go ahead and use it. In general, the recommendation for North America is don't use vinegar. The recommendation for Australia is always use vinegar. So kind of just go by your local rules and kind of guidelines when you see them. These guys are really no fun. Initially, there's very severe pain and it comes on quickly. It can be disorienting. It can cause panic. And there's a high risk of drowning with these patients. That's when a lot of the deaths actually occur. Patient shortly after being stung can develop a multiple interlaced whiplash pattern similar to the Portuguese man of war. And systemic symptoms are common. Cardiac effects tend to dominate. There's usually fluctuating hyper and hypotension. There can be confusion, loss of consciousness, shock, respiratory distress with pulmonary edema, and paralysis has even been reported. If somebody is going to die or have very bad symptoms from a Chironex sting, usually it happens early. If the cardiorespiratory status is maintained throughout the first hour, the prognosis is usually pretty good. And if the patient does survive, the wounds often do ulcerate and become scarred over. This is from a case series from day 1 to 4 months out. And you can see the progression. It's, it starts off as kind of red and inflamed. You start developing worsening swelling. It'll then kind of start to involute a little bit and scab over, then ulcerates, and eventually will turn into a scar. There have also been reports of people getting stung and healing, and then you can get reactivation symptoms, almost like an allergy. The triggers aren't well known. It can be environmental. It can be something they eat, but patients do complain of recurrent pruritus and pain on the scars. This is an animal where there is antivenom, and this is definitely something I'd reach for. Box jellyfish can be deadly. So if you suspect a box jellyfish, or you're in an area where they're endemic and you have somebody coming in who's been stung and they're not looking too great, call for it early. Some other adjuncts are magnesium sulfate. It's been tried in cardiac arrest for these patients. There isn't good data, but I think there's a very low downside. If I had a patient like this, I would definitely throw 2 grams of magnesium at him while I'm coding him. As I mentioned, systemic symptoms can be severe. Not everybody goes into cardiac arrest. Steroids have been suggested as a way to try to mitigate these symptoms, and were worth trying if the patient's in significant pain or having pruritus or swelling, anything else like that. That being said, they do take a couple hours to take effect, so that's not something you're reaching for in a code. The last thing I wanted to highlight is, when I say this is the jellyfish that everybody talks about when they say box jellyfish, no, there are other species of box jellyfish. I grew up partially in Hawaii. This is a beach near where I grew up, and there'd always be box jellyfish warnings. In this case, it was the Carabidea alata, totally different species, painful, but by no means deadly. So just kind of know what people mean when they locally say box jellyfish. You might have somebody come into the ED be like, I got stung by a box jellyfish. And if you're in Australia, I'd be a lot more worried than if I'm practicing in Hawaii. This is a cool one. Next, I want to talk about irukandji. So this is actually a group of jellyfish. Any jellyfish that can sting you and cause irukandji syndrome is known as an irukandji jellyfish. The most common jellyfish is the Crucia barnesii, which is seen here. You can also see this is like a mallow king's eye, which is a kingslayer jellyfish. In general, they're all very small. And they can be difficult to see, often unnoticed by patients who are stung by them. This is their distribution, and due to it being made up of multiple different species that cause this syndrome, it's actually pretty widespread. Primarily clustered around Australia and Southeast Asia, similar to the Chironex, but it can be found elsewhere. And this guy has kind of a cool story. So irukandji syndrome, I'm going to get more into it in the next slide, but it's actually, think of it as a hyperadrenergic state, like somebody OD'd on cocaine, or they have like a pheochromocytoma or something like that. The syndrome was known before the causative animal was known. And there was a doctor in Australia, Dr. Jack Barnes, who suspected the jellyfish. So he did what any self-respecting Australian doctor would do. And he went out to the beach with his son and he caught one, and he went ahead and stung himself. And nothing really happened for a couple minutes. So he's, maybe it's not it. So he went ahead and he stung his son, and he stung the lifeguard too. And they ended up about an hour later in the ICU requiring critical level of care. So he did discover that it was this jellyfish that was causing the syndrome, and he got his name associated with the scientific name. So good for him. I'd be kind of pissed if I was the lifeguard and got shafted out of having my name on a jellyfish because I got stung too, but you take what you can get, I suppose. If you do get stung, the initial stung really doesn't feel like much. You can have some local erythema, dermatitis, but it often goes unnoticed by the patients. Usually there's a latent period between getting stung of about 5 to 120 minutes. 30 minutes seems to be the most typical before they start developing systemic symptoms. First thing people usually complain about is abdominal pain with these waves of muscle rigidity. It can encompass back as well, and then there'll be vomiting, diaphoresis, and headache. Next, there's usually a sense of impending doom, which is never good in a patient, that comes on, followed by severe systemic hypertension. Remember, this is like a hyperadrenergic state. For this reason, you often get myocardial dysfunction. So these are patients where if you suspect the syndrome, you're definitely getting an EKG and you're getting troponin, which I won't get necessarily on other jellyfish things. And you need to go ahead and start controlling it. So first, as I'm sure there's no surprise at this point, vinegar is recommended. These are Australian jellyfish. So if the rare event you see a tiny little tentacle on somebody like this, go ahead and irrigate it with vinegar. But I'd probably reach for the hot water first, even if they're not having pain. Again, these are heat labile venom, so you can start to try to denature anything that's in the local area. If they're having pain still, lidocaine, morphine, do what you got to do. But really, you want to treat the high blood pressure and the systemic symptoms. The literature recommends nitroglycerin. So a nitro drip is first line. That works very well in conjunction with lorazepam or other benzos. These work very well to help control the symptoms of abdominal pain and rigidity as well. So these are the first two I'd reach for. If the blood pressure is still uncontrolled, then phentolamine or any other alpha blocker is something that you could definitely reach for as well on top of it. Just be careful when you start combining all these mechanisms together, because there have been reports of rebound hypotension. And then something in severe cases that are totally uncontrolled, again, is mag sulfate. I wouldn't use it in first line, but if somebody's really uncontrolled, reach for it. There's a very low downside to using it. A couple things don't to do or not to use for these animals is beta blockers. Like cocaine, if you use a beta blocker, especially if you're not already using an alpha blocker, there's a significant risk of unrestricted alpha cascade, and you can make things a lot worse. Some sources actually do recommend using Chironix antivenom. It's a totally different venom with a totally different syndrome. I've seen no good data supporting it, and I found a lot of sources that recommend against it as well. In my opinion, the risk of anaphylaxis is too high. I don't see any upside to using it. And it's also relatively rare and can be difficult to get a hold of. So I would probably not reach for box jellyfish antivenom in these patients. And just to reiterate, please don't ever pee on your patients. There's no medical indication, despite what you might hear online. All right, so those are the really big boys of this category. We're going to move on to some more common and less deadly ones. First is the sea anemone. It's a predatory animal of the order Actinaria, and it's actually named after a terrestrial plant, also called the anemone, which I had no idea existed until I started doing research for this project. They have the stinging nematocysts in the tentacles that surround a central mouth, and they usually have a stalk that they use to anchor either to the seafloor or to coral. They can move, albeit very slowly. They're not going to chase you down. This is on the order of like inches every day. But typically you'll find them looking like flowers or anchored to rocks. Of note, they are voracious predators. They'll eat whatever they can get a hold of. This is the giant green sea anemone eating a cormorant nestling. This is taking an organ. The nestling was probably dead when it got a hold of it, but still, as a lesson, don't leave your hand in their mouth for hours at a time. They probably will try to eat you. I remember playing with these guys as a kid. They're kind of cool. Most species of these don't have tubercles on their nematocyst long enough to go all the way through your epidermis. So you actually really, if you're touching them with something like your palm that has thick skin, you won't feel anything other than a sticky sensation. I remember playing with them and touching them and messing around, and I never got any kind of local reaction from it. That being said, if you do touch them with a skin that's thinner, such as your armpit, groin, forearm for some people, belly, there have been reports of localized pustules, urticaria. You can get this kind of serpiginous dermatitis. Usually it's pretty mild. It'll have a blistering kind of hot sensation, maybe pinpricks, but you typically don't need anything more than like ibuprofen, Benadryl if it's itchy, hot water, everything we've already talked about. You will hear case reports of like nephrotic syndrome and other weird stuff happening from it, but that's the exception, not the rule. I would not be worried about a patient who had a sea anemone sting, but that being said, treat the patient in front of you. If they're presenting weird and they say they were stung by a sea anemone, just high index of suspicion, treat what you see. Next is fire coral. So this is not a true coral. It's actually also a hydrozoa. It kind of forms its own group of hydrocorals. These are unique in this group in that they actually have an exoskeleton composed of calcium, like other corals. So they can cause abrasions and cuts if you end up touching them. They're of the genus Milliporia, meaning 1,000 holes. And they get that name because they have all these tiny little holes through their exoskeleton, through which the tentacles that have the nematocysts protrude. These guys are sedentary and they're found in a very large distribution worldwide in the tropics. Of note, not in Hawaii. So I had to learn about them for the first time when I went diving in the South Pacific. You can typically identify them by their bright coloration. They are usually orange or red, yellow, and they can often have this white tip, this kind of coloration, makes it easy to recognize. Of note, if anything is bright in nature, and especially in the water, that's a good sign you shouldn't be touching it. So just don't touch any bright coral. Don't touch any coral. You can get coral cuts, which are no fun too. This is off Key Largo for those of you in Florida. So this is something that you will definitely see if you go diving around Miami or the Keys as well. If you do get hit by it, usually it's described as a burning and itching pain with pinpoint red lesions that can sometimes blister or ulcerate. There have been reports of delayed reactions like dermatitis or urticaria that you can see here. This is just a case study of a fire coral sting over day 1 through day 18 right here. Interestingly enough, even though the sting is typically not that bad, sometimes you can get ulceration, scarring, and hypopigmentation afterwards. So something to warn your patients about. If I saw somebody coming in with a sting like that, I'd be recommending they stay out of the sun, put sunscreen on it, cover it with bacitracin. Just try to mitigate. Oh, sorry, my cat just jumped up. Just to try to mitigate any kind of further scarring. For symptomatic control, it's everything we already talked about. Hot water works well for the pain. Lidocaine if they need it, if it's in a small area. You can give them topical lidocaine, like kind of jelly too. Prednisone, topical prednisone, or antihistamines for itching or any other symptoms should be fine. Again, there have been weird case reports of stuff like thoracic nerve paralysis and crazy stuff happening from it. The exception, not the rule. So, I'd be at a low index of suspicion to keep somebody from a fire coral sting in the hospital. They maybe can develop systemic symptoms if it's a large area of envenomation. It would just be stuff like nausea, vomiting, GI, abdominal pain, that kind of thing. I would treat it very similar to a Portuguese man of war sting if they were coming in and having systemic symptoms. So not something that's going to chase you down, usually relatively benign, but if somebody rolls into a patch of it, it can get a little worse. All right, so I know we're moving very fast, but we're going to switch gears again. Now we're going to talk about animals that bite you. So these are a little different as far as an approach. These animals are primarily concerning because their venom is paralytic. So there are a couple of considerations you want to have with these that you wouldn't have with animals that sting you. Again, make sure the situation isn't dangerous, but because these are paralytics, there's a very high risk of drowning or people becoming weak in the ocean. So get them somewhere safe. The primary difference in how you're going to approach these in the field as opposed to stings is the pressure dressing is actually indicated in this case. So pressure dressings have been shown to help retard the absorption of venom and buy you time to get somebody to an advanced care environment like the hospital. In order to do a pressure dressing, you want to find the wound wherever they were bitten and start wrapping it using a stretchy ace bandage or something similar. You typically want to use about 50 millimeters of mercury, about as tight as you'd wrap a sprained ankle. You'll go up and down trying to wrap as much of the extremity as possible. After that, you want to splint it. You want to try to minimize any motion. Don't let the patient get their heart rate up because that's just going to increase the rate of absorption. And these actually work relatively well in the reports that I've read. I've seen case reports of people coming in with the pressure dressing on, feeling fine. They take it off and then very shortly after go into respiratory paralysis. So definitely something to consider if you have the ability to do so. Something else is because these are paralytics, patients can often decline relatively quickly without being able to call out to you or let you know that things are going poorly. All right, don't leave them alone if you can avoid it. Try to have somebody else go and enlist help and stay with the patient. All right, they can decompensate quickly. So if you have the tools in the field, be ready to give CPR, be ready to give rescue breaths and take over the airway if you can, and try to get them to the hospital as soon as you can. This is not something that I would blow off. If anybody gets bitten by a sea snake or a cone snail, any of the animals we talk about, I would take them to the hospital and have access to advanced medical care. Once they're in the hospital, mostly it's supportive care. There is antivenom for sea snakes, and we'll talk about that when we talk about it. But in general, it's going to be, take the pressure dressing down, see how they do, be ready to intubate, be ready to give antivenom if it's available, always be ready to treat anaphylaxis, and then be ready to do supportive care. If they're hypotensive, give them pressors. If they're bradycardic, give them atropine. Do what you have to do to take care of them. These patients should usually be admitted if they're presenting early due to the risk for decompensation. And the wounds, as you can imagine, an animal that bites you in the ocean can be quite dirty. And so antibiotics are also indicated. First animal I want to talk about is the cone snail. And this guy's pretty cool. It's a part of the Conidae family. They're a class of predatory gastropods, primarily found in a tropical distribution, but there's a species that can be found off Southern California and more temperate waters as well. They're characterized by their cone-shaped shell, usually brightly colored, which entices people to pick it up and is a problem, but they can also be darker and brown, depending on their environment. They have two appendages at the front. One is a siphon up here, which they use to respire, and the other is a proboscis, which they use to hunt and interact with the environment. The proboscis is kind of a muscular tentacle. It can move around all the way around the shell. And the way these guys hunt is they actually have these modified teeth called radula. They look like harpoons to me, and they're hollow. So what they'll do is they have this radular sac where they have all the preformed teeth. They have a venom bulb, which will contract and load up a harpoon with venom. And then it'll get migrated to the front of the tentacle, and they'll be able to use it to reach out and strike somebody, almost like a harpoon. The venom is very, very toxic, and often enough to almost immediately paralyze any kind of small prey that they come across. So if they do tag a fish, it'll almost immediately be paralyzed. And then what they'll do is go ahead and engorge their stomach and actually digest it whole right there. So kind of a cool predatory snail. Luckily for us, we are too big for them to engorge their stomach around, so they can't ingest you, but they can still have a pretty nasty effect on you. Do know that the proboscis is long enough to get all the way around the shell, so there's no safe place to pick up these snails from. Holding it from the back will not protect you, and the radula is quite sharp. There are often people that will put it in their pocket and get stung through their pants or bitten through gloves and the same. So my suggestion is just never pick one of these guys up. If you do end up getting bitten, what's going to happen? Well, I looked long and hard, and I apologize. I couldn't find a picture of a cone snail bite online. This is a bee sting. I've been told they look similar for those of you who've never seen a bee sting. And what do you feel? Well, this is also somewhere there's somewhat mixed reports. I've heard it can be very little pain to no pain at all because it goes numb almost immediately. This is a gentleman who says he was left convulsing in pain. You can make your own judgment if he looks like he's in severe pain to you from a cone snail sting. So who knows? Maybe it will hurt a lot. Maybe it won't. Could go unnoticed. It's primarily concerning for its systemic effects. So usually what happens with mild envenomations, you're going to get paresthesias, weakness, nausea. But if it's a more severe envenomation, it's going to progress to paralysis, respiratory arrest, and then from that, cardiac arrest. How do we treat it? Well, this is one of the few animals that bite where it's also a heat labile venom. So hot water, even if it doesn't hurt. I know you guys are getting sick of hot water, but use it for everything. You can actually help them quite a bit. After that, pressure dressing like we already talked about, and then be ready to intubate, be ready to do CPR if they decline. There's no anti-venom for this, so it's really just supportive care. Any patient that gets bitten by a cone snail or you suspect it, I would admit them to the hospital or observe them for at least 24 hours. Symptoms generally tend to peak in about 6 hours, and if the patient makes it 24 hours, the prognosis is quite good. But this isn't somebody I'd send home because they're like, oh, I just have a little bit of tingling around the site. This is somebody you want to keep and watch because they have a significant probability of declining if they were envenomated. This is one I'm sure a lot of you guys have heard about, the blue-ringed octopus. It's a Haploclenia in the genus, found in the Indo-Pacific region. I typically associate it with Australia in my mind, which is where they got their fame from, but they can be found as far as Japan and the Indian Ocean. They usually weigh about 10 to 100 grams, a little bit smaller than most people expect. And it can usually fit in the palm of your hand. Their coloration can vary. They have some control of it. If they're trying to blend in, they can be kind of a dark, muddy brown with these small blue rings. If they're agitated or they want to stand out, they can make themselves turn this bright gold with these vibrant blue rings, which is kind of a problem because it makes kids and other people want to pick them up. They're very pretty animals. They have a beak like most octopus. I don't know if some of you have never seen an octopus beak, but the larger ones can take a big chunk out of you. Luckily, this guy's small enough, his bite isn't going to do much trauma, but he has a secret weapon. He has the tetrodotoxin is the venom that he makes. It's a sodium channel blocker, and again, it's a paralytic. They don't actually inject through the beak. They can inject the venom near their jaws. So they actually have kind of a cool hunting technique. If they're very hungry, they're just going to grab whatever they want to eat and bite it. But if they're not, sometimes they float above it, and they'll actually inject their venom into the water and let it kind of seep in around their prey, and the prey will get all loopy and paralyzed, and they'll come in for the coup de grace. So very cool. In general, they're not aggressive. They'll try to flee as opposed to bite you. But unfortunately, poorly informed adults and children who don't know any better will often try to pick them up due to their pretty coloration. And that's when most people get bitten. This is a very classic picture of a tourist taking a picture. He did not get bitten, luckily. But when you see an octopus with the blue rings vibrant like this and bright yellow, it's very much a danger sign. Again, if it's bright underwater, don't touch it. If you do get bitten, the initial bite may seem like not a big deal. It's typically minimal, doesn't hurt a lot, and can even be hard to notice. But then the patient is going to start developing some perioral tingling, maybe some nausea and GI symptoms. Typically, what comes next is bulbar muscle paralysis, so the muscles in your face. You can get these fixed, dilated pupils, some difficulty speaking, difficulty swallowing. And if it goes further than that, that'll then progress to full limb paralysis, respiratory paralysis, and then cardiac arrest. Of note, hypotension and bradycardia have also been reported and not associated with respiratory paralysis, so it does have some cardiac effects. And the patient is actually conscious the entire time this is going on. This is like giving somebody succinylcholine and not giving them any Versed. So it can be very terrifying for the patient. Stay with them the whole time, talk to them, let them know you know what you're doing and that you're going to take care of them. Don't position them like this because there's a high risk of aspiration in a paralyzed patient. Position them on their side, put up the pressure dressing, get them to the hospital. If they have a severe envenomation, you're going to have to inevitably intubate them and take their airway, so be ready to do so. Ideally, you're not going to, again, take the pressure dressing down until you're ready to give them definitive care. Usually, the paralysis will start to recover by about 12 hours, though the muscle weakness and kind of the spasms may persist. Patient will usually survive if they make it 24 to 48 hours. So if you can bridge them for the first day or two, they have a good outcome typically. Again, this is a patient I would admit for any bite less than 24 hours old, just due to the risk of decompensation. Our last group in this category is the sea snake. So these are elapidid snakes, similar to the elapidids you'll find on land, the neurotoxic ones. They form a subfamily of Hydrophinae. They're air breathing, so they're similar to whales or dolphins in that they have to come up to the surface to breathe. And they're actually pretty, I think only whales spend more time in deep water than these yellow-bellied sea snakes. So you can find them out very, very far. The range is large. It's mostly tropical and subtropical, though there have been sightings off California and in colder waters. And you can differentiate sea snakes from land snakes by this paddle-shaped tail. Sea snakes are the only ones that have this kind of flattened tail to help them swim. Oftentimes, land snakes will take a dip in the water, so sometimes you'll see non-sea snakes in the ocean. So if you do see a snake, keep an eye out for the tail. You'll be able to distinguish it. There are two main groups of sea snakes, the banded or diving snakes, and then the pelagic ones. These guys tend to stay close to shore. They can dive deep up to 100 meters, and they hunt in and around the coastline. They actually lay their eggs on land, so sometimes you will encounter them on land, or they're not very mobile on land at all. And that's opposed to these pelagic snakes, the yellow-bellied ones. These guys drift far afield. Sometimes there have been reports of multiple snakes banding together and forming almost a raft of sea snakes, like out in the middle of the ocean. They mate and they have their young out in the water, so you're never going to see these guys on land. Something that's different about sea snakes compared to most land snakes is they have relatively small fangs. For this reason, most of their bites actually don't result in envenomation. Only about 20% of bites result in envenomation. That being said, they have been described, depending on who you talk to, as either inquisitive to aggressive. So bites are not uncommon in areas where they live. Most bites occur if a fisherman is having an argument with a snake about a fish or something else like that, or you're provoking them. I have seen these animals in the water. I've had no trouble with them myself, but there's not something where I'd go and try to get a very close look at.
Dr. Barry,
Yeah.
we give you we have about 5 minutes left, so we can.
Oh, all right. We're going to go quick. So sea snake wounds. All right. Usually the bite is not a big deal. All right. It doesn't feel like anything, and it won't hurt very much, but it's also a hemo and neurotoxic venom. So you got to be careful. There's usually a latent period of about 10 minutes, and then it can be a feeling of differentness, euphoria, anxiety. Sometimes people report thirst. Next typically comes weakness, blurry vision, the diplopia we already talked about, like with the blue ring octopus and the beginnings of paralysis. And this will go to muscle spasms, full respiratory paralysis, and cardiac arrest. Other than that, it is also myotoxic, so you can get rhabdomyolysis and kidney failure, so something else to keep an eye out. Sea snake antivenom is available, and I would definitely call for it for anybody that has a sea snake bite and any kind of systemic symptoms at all, even if it's just feeling a little weird. Do know that if you can't get sea snake venom, you can use polyvalent land snake or king snake venom, or I'm sorry, tiger snake venom, antivenom, to try to treat these patients. The wounds are often very dirty. This man was bitten by a sea snake and then went fishing. He was not paralyzed, but he almost lost his finger due to an infection. So definitely cover with infections. Hallmarks other than that are supportive care and pressure dressings. Last but not least, I know these aren't venomous, but these are often tested, and this is something you'll encounter more often than marine stings. So I wanted to talk very quickly about animals that you bite, so the poisonous or toxic animals. As general concepts, a lot of this has to do with what you eat. If it's stored improperly, you're at a much higher risk, and if you're eating the wrong species of fish, you're at a much higher risk. I always, when I travel, like to talk to locals in the area and kind of get their idea of what's safe to eat and what's not. Take it with a grain of salt, though. I've been told multiple times that you can distinguish ciguatera by whether or not flies land on the fish meat. This is not true. So just talk to knowledgeable people, but have a high degree of suspicion. The first thing I want to talk about is ciguatera. It's caused by a toxic dinoflagellate, Gambardiscus toxicus. It was discovered in the Gambier Islands, which is how it gets its name. It produces ciguatoxins and myotoxins. And what happens is these herbivorous fish will dine on the dinoflagellate, they'll eat it. They'll get eaten by carnivorous fish, so you get this biomagnification of the venom, and then when you eat it, you get the symptoms. The animals you got to be careful of are primarily carnivorous reef fish, grouper, barracuda, moray eel, amberjack, that kind of thing, but it's by no means limited to it. Oftentimes, there'll be a disturbance to the environment, like a boat wreck or a spill, and that'll cause a bloom of ciguatera, so you'll have outbreaks of it. You can look online, at least in Florida, if there are any outbreaks going on currently. So check online, do your research, and you can probably avoid eating or getting poisoned by ciguatera. As far as symptoms go, they typically onset within 2 to 6 hours. You'll have GI symptoms like nausea, vomiting, diarrhea, cramps. You can have dehydration. You can also get bradycardia, hypotension. You can get these paresthesias, but probably the most known or well-spoken about one is this hot-cold temperature reversal. It's technically not true. It's actually called allodynia, meaning that if you apply a cold stimuli, you're going to get a burning sensation, but hot still feels hot. Other than that, there have been a relatively common symptom is a metallic taste or feeling like your teeth are loose. I've actually seen that on a boards exam, so know that. Treatment is primarily supportive. You can use atropine for bradycardia. If they're getting dehydrated, you got to give them IV fluids. Do know that you can try things like amitriptyline and other things like that for the paresthesias, but that's not something you typically do acutely. These can last some time, and that's when you'd use it. Only thing I wanted to highlight for them is there was actually, in the 80s, there was some patients that got very sick with ciguatera, and they suspected cerebral edema, and they gave mannitol. They made a wonderful recovery. The same authors after that then did a case series where they had about 28 patients, and they gave mannitol to all of them and reported really good recovery. So they were like, oh, maybe this works. The only randomized control trial I could find was a relatively small number of people, but it noticed no difference between mannitol and normal saline. So mannitol is something you can reach for if the patient's very sick. It doesn't have great data behind it. I would probably reach for it if they're, having cerebral edema or altered mental status, anything like that. Do know it's a diuretic, so don't give it to somebody who's already dehydrated without already giving them volume back. Tetrodotoxin, I'm going to brush over very quickly. It's basically what happens to you when the blue ring octopus bites you. It can also be found in certain fish, newts, horseshoe crabs, and frogs. Primarily, it happens when somebody eats fugu, which is the pufferfish, and this is usually in Japan. Symptoms are, again, the similar kind of headache, nausea, vomiting, perioral tingling. You can get the similar kind of diplopia and the dilated pupils. You can get full paralysis, hypotension, respiratory distress, and even death. If untreated, death will occur usually within 2 to 6 hours. But if it is treated, you can usually bridge them through. There's no specific treatment. It's just supportive. Do know that deaths have been reported in as little as 17 minutes. So if somebody looks like this and they're their favorite fugu restaurant and starts feeling well, get them to the hospital very soon. Last but not least is stromboid. So this is actually caused by bacterial overgrowth on poorly stored fish. Bacteria will grow on fish and they produce something called histidine decarboxylase. This will convert histidine to histamine. And when there's a large amount of histamine and you ingest it, you end up with something called stromboid. People will tell you this can only happen in red oily fish. This is not true. It can also happen in white fish like mahi-mahi. In fact, 80% of the cases, I think in 2006 to 2013 by the CDC were ahi, which is tuna, and mahi-mahi. But you can also get it in like bonito, bluefish, sardines, and amberjack as well. Some people will say it has a peppery taste to the meat. So if you're eating a fish that's been left out in a sea market for a long time and it tastes peppery, maybe stop. Not the best idea. Typically, this presents almost like an allergic reaction. You'll have a rash, itching, urticaria, GI symptoms. Some people do get tachycardia. And one of the most dangerous things is bronchospasm. Usually people will do okay with just some Benadryl, and you can give them some steroids if they're really having systemic symptoms. But if they are having respiratory distress or anything that looks to you like anaphylaxis or a bad allergic reaction, reach for your epinephrine and then reach for your albuterol. All right. Of note, this is usually not a true allergic reaction. So it's a preformed histamine that's causing you the symptoms. You're not allergic to the fish. Usually you can determine this just based on the scenario. If multiple people are getting sick from eating the same fish, probably not an allergic reaction. That being said, a true fish allergy should be on your differential. And if you really can't determine, you can send a tryptase, which would be high in anaphylaxis and not in stromboid. You can also send a urinary histamine, which would be high. I've never done it or even heard of it being done, but just things you can do. You can also send the fish meat to be tested. So they can test the amount of histamine in the fish meat and determine if that's what's causing the symptoms. So I know that was a lot. Sorry, I got a little rushed at the end. I just wanted to break it down into very basics. So first and foremost, good emergency medicine care on the beach. Make sure you're safe, make sure your patient's safe, symptomatic care. The next thing I do in these patients is try to determine, is it a bite or is it a sting? If it hurts a lot, it's probably a sting. If it doesn't, be more cautious about a bite. Also, the animals that bite you typically are more noticeable than the animals that sting you. So your patient might be able to tell you. If it's a bite, clean the wound, pressure dressing, get them to the hospital. If it's a sting, clean the wound. If it's anything but a physalis or a man of war, maybe some vinegar if they have a tentacle wrapped around it, remove whatever spine is embedded if it's safe to do so, and then hot water. I would even reach for hot water for some of these because, hey, if it's a cone snail, it's going to help. In the hospital, we're doing pain control with our local anesthetics. We're giving parenteral opioids if needed, primarily supportive care. Intubate if they need intubation, ACLS if they're going to cardiac arrest, treat their symptoms. Other than that, there are a couple animals that have antivenom. This is, again, the chironex, the stonefish, and the sea snake. So any of those, go ahead and call for it early. And then poison control is always there to help you. These guys are great, always there. They love the call and they'd love to get a case like this because they're usually pretty cool and rare. So don't hesitate to call. These are my references. And other than that, any questions?
Brilliant. Thank you so much, Dr. Berry. Phenomenal talk. Regarding questions, guys, if you have any questions, we've not got too many now, so feel free to write them in the chat. And when you do, if you can put your name and the institution or the med school that you're from, brilliant. So we have an idea of who's asking what. While that's coming in, I've got a couple for you, Dr. Berry.
Sure.
And also really appreciated your short summary at the end. But for me, the big takeaways were, when in doubt, hot water.
Absolutely.
If it's bright, don't touch it.
100%.
And don't pee on patients.
At least not in a medical setting.
Okay, brilliant. And for anybody who is already slightly anxious about the sea and fish, I'm not sure any of us are going to go near the sea again. But yeah, fantastic. So my question to you is, you mentioned the risk of anaphylaxis with antivenoms.
Mm-hmm.
How significant a concern is that? How often is that a problem?
So off the top of my head, I don't know the exact numbers, but remember, antivenoms are typically derived from an animal antibody where they inject a small amount of the venom, and then it's this foreign, cross-species antibody that they're putting into you. So the risk for anaphylaxis is real, and it's relatively high. I don't have the exact number, but I would not give antivenom unless I had my crash cart ready to go, because you may be saving their life in one way, but if their throat closes up and you can't treat it, then you just killed the patient. So be cautious. If you're in the emergency room setting, usually your medicines that you need to treat anaphylaxis are within 15 feet at any given time. So it shouldn't be too much of an issue. But if for some reason you have only the antivenom and nothing else, then I'd be a little more wary and maybe hesitate to give it unless the patient was actively dying.
Fantastic, thank you. So I've got a couple of questions that have come in now. One from Matthew Holman, UCF.com. He asks, I know you mentioned it, but how hot should the water be? When we're talking about hot water, what we're talking about?
So what they quote is 43 to 45 degrees. Once you get above like 46.8 to 47, that's when you can start getting the risk of injury. again, if you don't, like I don't carry a thermometer with me, I just make the water kind of hot and I put my hand in it and make sure I can tolerate it. And I have them put something other than the stung part of their body in it to make sure they can tolerate it as well. If that other part starts to hurt, then they got to pull their hand out of the water.
And in terms of what it's doing, you mentioned about denaturing hot labile toxins. Is that the main mechanism?
From my understanding, yeah. There's probably some benefit in the heat too. It can be a distracting sensation, but usually you're breaking down the venom itself, and that's how you're getting the majority of the relief.
Okay, fantastic. We've got one from Larry Jones here. He asks, in scombroid poisoning, do you need to block both H1 and H2 in the treatment approach?
I would, because remember, it's preformed histamine, so it's going to act on both receptors. So I would use something, Benadryl usually works pretty well. I don't think you need to get too fancy with your choice of antihistamine.
Okay. Andrew Simons asks, I was diagnosed with a case of ciguatera. Was that the right pronunciation?
Mm-hmm. Yeah.
Actually, I wasn't diagnosed. I diagnosed.
Oh, apologies.
Oh, that's awesome.
I misread it.
Diagnosed.
Feel free to ask the question, seeing as you're on air now. Go for it.
Well, I'll say is that, the woman had the cold hot reversal, and I was thinking about it, and I did a travel history, and she had just gotten back from Puerto Rico. She had eaten lots of reef fish. And I couldn't believe that I was seeing ciguatera in Buffalo, New York, but there it was.
That's awesome, man. You're never going to diagnose it if you don't think about it. So props to you.
Right. Take a good travel history.
And then Shilpi proposed the question herself. She asked, if you get stung far out into the ocean, what's the best advice for sting management until you make it to the hospital?
How far into the ocean are you? Are you on a boat or are you swimming?
So she suggested we're on a dive boat, potentially.
So if you're on a dive boat, the first thing I do is try to get the patient up onto the boat and try to identify what stung them. Usually you're going to be able to tell pretty quickly if it's a severe sting versus not based on the degree of pain. I would try to do wound care first and foremost, irrigate it, remove any foreign bodies in the barb. After that, hot water, and then try to get them to the hospital as soon as possible. At a dive boat by itself, you're going to be very limited to BLS. So if they do start developing anything like pulmonary edema, you're not going to have the means to manage it. So if they say, I put my hand on a rock and now it really hurts and it's swollen and I'm having difficulty breathing, you got to turn that boat around. But in the field, it's just good BLS, and then hot water is really the thing I'd recommend.
Okay.
Unless it's a bite, in which case pressure dressing tube.
Yeah. How are we doing for time, Claire? Do we have room for a couple more questions?
As long as Dr. Berry is willing to humor us, then definitely.
Please.
All right, brilliant.
One or two more questions.
Okay, we'll take two more. Arthur Levine asks or says, we've seen minor jellyfish stings in the Gulf of Alaska from lion's mane and common sea nettles. Based from what you went over, would you recommend seawater and then hot fresh water? And what would you recommend for a jelly sting in the eye?
Yeah, so for the Gulf of Alaska and like lion's mane and sea nettles are relatively common. Again, there are a lot of really cool animals I didn't have a chance to talk about. But in that case, I would recommend a seawater irrigation, try to remove any obvious tentacle, at which point I'd apply either hot packs or hot water and try to help with the pain. For a sting to the eye, I would probably treat it like any other foreign body in the eye. So I would try to irrigate it. I'm not going to be using hot water directly to the eye. I don't know if there's anything more specifically you would do apart from consulting opto and making sure they have adequate follow-up, because I think there is a risk of having the corneum ulcerate and everything else like that from it.
Yeah.
They also may require antibiotics or be at a higher risk of like endophthalmitis or anything like that. But unfortunately, I don't have any specific recommendation apart from symptomatic care for the eye.
Brilliant. From Ileana Claudio, this will be the last question then. In the past, I've read about a morphine-like analgesic being made from the cone snail. Are you aware of any other drugs currently being made from these toxins?
So the conotoxins, I'm not sure about. There was for tetrodotoxin some interesting data about using it as possibly an analgesic, and it might be the next Botox and whatnot. So far as I know, I think there probably is ongoing research in a lot of these marine venoms, but I don't know if there's actually something. I don't think there's anything on the market, and I don't know how close it is to coming. But as you can tell, a lot of these have very broad systemic effects. So if we can kind of narrow down on what compounds cause it, the medical applications are very much there. So it's a cool area for research.
Fantastic. Thank you very much. I think that'll be us for questions then. And also just to say, there's been a lot of love for your cat in the chat as well. We very much appreciate having him around.
All right. Well, thank you so much for having me. I'm sorry we got rushed at the end, and I'm happy to take any questions by email or anything like that in the future.
Yes, thank you so much. We really appreciate all the time and the effort you put into this presentation. I know I definitely learned a lot, really loved the focus on treatment. I found that very helpful and practical.
Okay, thank you everybody for coming, and shout out to my board members for doing an awesome job leading the talk today. Hopefully I see you guys next week for rescue medicine, and stay well, stay safe, and let's keep exploring, y'all. Have a good night.
See you soon.
Bye.
Good night, everyone.